In this mini conversation, we are going to explore the concept of receptor subtypes as it pertains to the peripheral nervous system and drugs that will potentially act upon these receptors. We will discuss what a receptor subtype is and why the receptor subtypes matter. So, first, let's answer the question regarding what a receptor subtype actually is. And receptors that respond to the same transmitter are different from one another. So, we are going to call them receptor subtypes. So, for example, we have our peripheral receptors responding to acetylcholine, which can be found on the ganglia of the autonomic nervous system or the ANS, but also can be found at the neuromuscular junctions as well as the organs that are regulated by the parasympathetic nervous system. But even though all the receptors are activated by acetylcholine, we do have evidence that the receptors at three different sites really differ from one another. So, again, activated all by acetylcholine, but will have a different reaction. So, altogether, these receptors belong to the same major receptor category, remembering that the category is the cholinergic receptors, but sufficiently they're different because they have distinct receptor subtypes. So, how do we know that receptor subtypes actually exist? And really, it's because we have been able to observe the responses to different drugs. And here on table 12.1, this illustration is showing you the different drug responses that help to lead to the realization that receptor subtypes exist. And the data that's been collected and summarized here is a result of an experiment that was designed to study the effects of the natural transmitter acetylcholine and a series of different drugs that you see here. And you can see the difference between the skeletal muscle responses and the ciliary muscle responses as well. Remembering the ciliary muscles are responsible for how our eye focuses for near vision. Now, although skeletal muscle and ciliary muscles both contract in response to acetylcholine, the tissue differs in their responses to the actual drug. So, we are going to discuss what those selective responses are to the different tissues and see how these responses reveal this existence of receptor subtypes. Again, answering the question of how we know that these subtypes exist. So, the first thing we're going to look at is really at the synapse itself. At the synapse of the the skeletal muscle and the ciliary muscles, we have acetylcholine being the transmitter that's employed by neurons to elicit a contraction. But both types of muscles will respond to acetylcholine, ciliary and skeletal. It's safe for us to conclude that both muscles have receptors then for this substance. Because acetylcholine is a natural transmitter for these receptors, we will classify them both as cholinergic receptors. So that's the major overarching category. So then what do the effects of nicotine on skeletal muscle and ciliary muscle suggest? Well, there's four possible conclusions based on this study. Because skeletal muscle contracts in response to nicotine, we can conclude that the skeletal muscle has a receptor at which nicotine can act upon. And because ciliary muscles do not respond to nicotine, we then can tentatively conclude that ciliary muscles do not have a receptor for nicotine. But we can also conclude a few more things. Because nicotine mimics the effects of acetylcholine on the skeletal muscle, we can also conclude that nicotine may act at the same skeletal muscle receptors where acetylcholine can act. And because both skeletal and ciliary muscles have receptors for acetylcholine, but because nicotine appears to act only on acetylcholine receptors on the skeletal muscles, then by conclusion, we can tentatively agree that the acetylcholine receptors on skeletal muscles are then different from those acetylcholine receptors on the ciliary muscles. Okay, so that is just one example. Our next question is, how can drugs be more selective than natural transmitters at each of these receptor subtypes? So the receptor subtypes again are nicotinic versus muscarinic receptors. And then the overarching or broader category is that they're both cholinergic receptors. Okay. So the question again is, well, then how can drugs be more selective? Well, if you look at acetylcholine here being the natural transmitter, you can see the two semicircle shapes fitting in both nicotinic and muscarinic cholinergic receptors. However, when pharmaceutical companies or chemists more specifically make new drugs, they can make them more specific to the receptor site. So the drug nicotine, you see that we have the two semicircle shapes plus the triangular shape that's going to fit specifically into the nicotinic cholinergic receptor, but not into the muscarinic cholinergic receptor. Whereas the drug muscarine will fit only in the muscarinic cholinergic receptor because it has the two semicircle shapes plus the square shape here, and it's not going to fit then in the nicotinic receptor. So by synthesizing chemicals that are structurally related to the natural transmitters, we have been able to produce drugs that are more selective for the specific subtypes. And they're more selective than just the natural transmitters acting alone on those sites. Now, to expand on that previous question, why do receptor subtypes exist? But now, why do they matter? Well, there are some physiologic benefits of having multiple receptor subtypes for the same transmitter, but it's not really obvious. So, really, as noted before, if it weren't for the creation of some of these drugs, we wouldn't have even known that these receptor subtypes existed at all. And although the receptor subtypes are of uncertain physiologic relevance from the viewpoint of therapeutics, it is still a valuable concept. The presence of receptor subtypes make it possible for a dramatic increase in drug selectivity. So what is drug selectivity? Let me give you an example. Because we understand the existence of subtypes of cholinergic receptors, drugs were developed selective for only those receptor subtypes. And it's possible then to influence the activity of only certain cholinergic receptors as opposed to all cholinergic receptors. So, for instance, if we're only trying to target the cholinergic receptors of the neuromuscular junction, and we do this without altering the activity of perhaps the cholinergic receptors that are found in the autonomic ganglia that are targeting the other organs of the parasympathetic nervous system. So, if we didn't know that there were receptor subtypes, a drug that acted on cholinergic receptors alone could possibly alter the activity of cholinergic receptors at other sites. So, understanding this makes it possible to then create drugs that will produce the action that we want very selectively so that we are getting the result that we want for that particular patient. So, if you are still a little confused about the selectivity or the importance of selectivity, I would encourage you to review the discussion regarding Mort and Merv that we discussed in the previous chapter. The concept of selective drug action is the most desirable quality that a drug can have. When we have a selective drug that can alter a specific disease process or effects, but we're able to leave the other physiologic processes unaffected, that is the goal. And many neuropharmacologic agents will display a high degree of selectivity. And this is because the nervous system works through multiple types of receptors to regulate the processes that are under its control. And this relationship between the multiple receptor types and the selective drug actions are illustrated by this concept of Mort and Merv. So we'll go ahead and review again Mort and Merv. So let's begin first. We're going to talk about Mort first. And Mort, he can perform 4 different functions that you can see here. He's able to pump blood, digest food, he's able to shake hands, and he's able to empty the bladder. Now, all four of these functions are under our neuronal control. And in all cases, this is exerted by the activation of this receptor, which we'll call A. Now, as long as Mort is a healthy creature, having only one receptor to regulate the various functions doesn't become a problem. It's quite all right. But selective physiologic regulation can be achieved simply by sending impulses down to the appropriate nerves if we don't have any issues. When there is a need to increase cardiac output, impulses are sent down to the nerves to his heart. When digestion is needed, we are seeing impulses to his gut or his stomach. And when he needs to void, you see that he's able to empty his bladder. So you get the idea. But having only one receptor when you are sick becomes an issue. So if Mort gets sick, when you only have one receptor, creating a therapeutic response becomes challenging. So let's assume that Mort develops heart disease, and we need to provide a drug that will help increase his cardiac output. So we try to stimulate his cardiac function by administering a drug that's going to activate on the receptor of his heart. But because we're trying to activate the receptor of his heart, the receptors on his heart are the same as the receptors on the other organs. So that drug that we're using to stimulate the heart and his cardiac function will also stimulate the other organs. So, in attempt to improving cardiac output, we might have some really silly and embarrassing side effects. It may cause compulsive handshaking, it may cause enuresis, and it may cause gastric ulcers. So now we have undesirable effects because he got sick and we're trying to trigger a response from one organ, although it's activating all the other organs. So that is why Mort is a more difficult patient to provide care to because he doesn't have selective transmitters and receptors. Whereas now we're looking at Merv. Now, Merv looks just like Mort, but Mort has more specific functions on the different receptor types because he has more than one receptor. Merv has different receptors controlling all of the same four functions that we talked about with Mort. But because of the simple but important difference, we have now selectivity. The selective drug action that was impossible with Mort because he only had one receptor, A, we are able to achieve more easily with Merv because he has receptor A, receptor B, receptor C, and receptor D. So if we have a medication that we're trying to target on receptor A, which is the heart, say he has the same heart condition that Mort had, and we're trying to help regulate that, then it's only going to work on the receptor A of the heart. And we're not going to have the other side effects for his hands, his gut, and his bladder. Now let's look. Our ability to produce selective drug actions in Merv is possible because the nervous system works through different types of receptors that help us to regulate the functions of the various organs. So now that we understand why we have the different subtypes, let's then now discuss the functions of cholinergic and adrenergic receptor subtypes. And understanding the receptor function is going to be essential for our understanding of the peripheral nervous system drugs. And by knowing that these receptors at where the drug acts is different, we're also going to be able to understand what the receptors do and then perhaps predict the major effects of the PNS drug that we are prescribing. I also want to stress that You can clearly just learn the names of the drugs and the mechanism of action really briefly and understand what the drugs are prescribed for. But really, without understanding the pharmacological um, background and the physiology of the receptor subtypes, it's really difficult to master the drugs. So make sure that you are doing both in conjunction with one another. Learn the different drugs and the details, but also relate it back to the actual functions of the cholinergic and adrenergic receptor subtypes. This table here is demonstrating the pharmacological relevant responses to activation of the three major subtypes of cholinergic receptors. We're going to look specifically now at nicotinic N, nicotinic M, and the muscarinic subreceptors or subtypes. And the responses to cholinergic receptor activation can be grouped in three major categories based on the different types of receptors involved. So let's look first here, activation of nicotinic N. And the N stands for neuronal. So these are the neuronal receptors that are promoting ganglionic transmission at the site of the ganglia of the sympathetic and parasympathetic nervous systems. Additionally, nicotinic N or nicotinic neuronal receptors can promote the release of epinephrine from the adrenal medulla. The activation of nicotinic M or nicotinic muscle receptors causes contraction of skeletal muscle. So activation of muscarinic receptors are going to be located on target organs of the parasympathetic nervous system and hopes to elicit an appropriate response from that targeted organ. Specifically, muscarinic activation is going to cause an increase in secretions from the different glands that are found in the pulmonary system, GI system, and even our sweat glands. Muscarinic activation will also cause contraction of smooth muscle in both the bronchi and the GI tract. It's also going to help slow the heart rate down, and it's involved in the contraction of the sphincter muscle of the iris, which is going to then result in miosis, which is a reduction in pupillary diameter, otherwise known as constriction. Contraction of the ciliary muscle of the eye causes the lens to focus for near vision. We also have dilation of blood vessels, and it helps with the emptying or voiding of the urinary bladder, as well as the bowels themselves. Now, muscarinic cholinergic receptors on blood vessels, we actually have to discuss that a little bit separately. These receptors are not associated with the nervous system. So, in that regard, there's no autonomic nerves that terminate at the vascular muscarinic receptors. It is important to note, though, that regardless of the physiologic relevance, the cholinergic receptors on the blood vessels, they still do have pharmacologic significance. We know that there are drugs that are able to activate these receptors that will cause vasodilation and then in turn will cause your blood pressure to fall. We're moving on to the functions of the peripheral adrenergic receptor subtypes, and you can look at table 12.3 to see the different receptor subtypes, the location, and the different responses. Now, there are four major receptor subtypes. We have alpha 1, alpha 2, beta 1, and beta 2, and then we have dopamine, which we'll talk about separately. You can see here that there are quite a bit of areas in the body or many locations where alpha 1s and beta 2 receptors can be found. For alpha 1, we can find them in the eyes, blood vessels, male sex organs, prostatic capsule, and the trigone and the sphincter of the bladder. We also see with alpha 2, we are going to find alpha 2 receptor subtypes only on the presynaptic nerve terminals. Because alpha 2 receptors are located on nerve terminals, they're going to be referred to as presynaptic, and sometimes you might even see them referred to as prejunctional. And these are all on the nerve terminal, not on the organs that are innervated by the autonomic nervous system. We also see with the beta 1 receptors, we see beta 1 on the heart and the kidneys. And you see that the responses to the heart is we're going to notice an increased heart rate, force of contraction, and also AV conduction velocity. B1 on the kidney helps to support the release of renin. Again, going back to B2, noticing that there are many locations that B2 can be found, these receptors are going to mediate several important processes. Activation of beta 2 receptors in the lung leads to bronchial dilation. In the uterus, it causes a relaxation of uterine smooth muscles. Activation of beta 2 receptors in arterioles of the heart, lungs, and skeletal muscles also cause vasodilation, which is an effect that's opposite to that of the activation of of alpha 1 on the same areas. Activation of beta 2 receptors in the liver and skeletal muscles will help with the promotion of glycogenolysis, as well as increasing blood levels of glucose. Remembering that glycogenolysis is the breakdown of glycogen into the byproduct of glucose. Additionally, the beta 2 receptors in the skeletal muscles will help to enhance contraction. And then lastly, we do have dopamine receptors in the periphery. The only dopamine receptors of clinical significance are going to be the ones that are located on the vasculature of the kidneys. Now, activation of these receptors will help dilate renal blood vessels, which will enhance renal perfusion. But in the CNS, the receptors for dopamine have a great therapeutic significance, and we'll talk about that in the next week when we go over the central nervous system. So again, here where you see dopamine, this is only related to the peripheral nervous system. Now let's look at the receptor specificity of the adrenergic transmitters. And it's a little bit more complex of a concept than the specificity of acetylcholine, because acetylcholine can activate on all three subtypes of the cholinergic receptors. You saw that it can activate the nicotinic N, nicotinic M, and the muscarinic. But not every adrenergic transmitter can interact with the other 5 subtypes. Remember, the transmitters are epinephrine, norepinephrine, and dopamine. So there's 5 receptors, alpha 1, alpha 2, beta 1, and beta 2, and then we have dopamine. And we're talking about the peripheral nervous system. Well, epinephrine is the only one that can activate alpha 1, alpha 2, beta 1, and beta 2. You see there's no activation of dopamine there. Norepinephrine can only activate the alpha 1, 2, and the beta 1. And then you see dopamine activates on alpha 1, beta 1, and only dopamine. But knowing again that epinephrine is only interacting with the beta 2 receptor, this can help you to understand what you think is going to happen. Remember that epinephrine is released when the adrenal medulla gets activated, releasing epinephrine, but it's not going to activate epinephrine or be released from the neurons. This is a function of epinephrine that helps us to prepare our body for that fight or flight response. So again, epinephrine is the only transmitter that activates the beta 2 receptors. And because epinephrine is released only for that fight or flight, we notice that we are going to undergo significant physiologic activation when the beta 2 receptors are activated. So let's think about in terms of what actually will happen. When we activate beta 2 receptors with the epinephrine transmitter, we are going to see dilation of blood vessels in the heart. Okay, so remember, connect this back to the fight or flight. We're also going to see dilation of blood vessels in the lungs and skeletal muscles. So we are increasing overall blood flow to those major organ sites. Beta 2 activation will also help to dilate the bronchi, relaxing the bronchi, smooth muscle, and increasing oxygenation. It's going to increase glycogenolysis, so making more glucose, and then increasing the available energy. It's going to help relax uterine smooth muscle. And this is really important because in a fight or flight situation, this relaxation of uterine smooth muscle will prevent premature delivery. So, accordingly, if you think of the physiologic requirements for success during the fight or flight response, you'll have a good picture of what the beta 2 responses will be when activated.